Hello to all, I am Dr. Vishnu. Welcome to the second part of diabetes series. In this video, I am going to talk to you about amazing facts related to insulin. And you know that insulin is a very important treatment strategy, whether it is type 1 diabetes and definitely in the advanced stage of type 2 diabetes. So in this video, I'll be talking to you about certain specific headings that I have made under the broad topic insulin. Before you watch this video, please make sure that you subscribe to my YouTube channel, definitely. And at the same time, do watch the previous video that I had made regarding diabetes, in which I talked about the types and pathophysiology. So if you haven't seen that video, please make sure that you watch that first. The link to that video will be shared in the comment section or the description section below. And you can also find it in my YouTube channel under a playlist named as diabetes. So it is for your convenience. So in that, the first video is regarding what are the types of diabetes or hyperglycemia. In that I talked about catamenial hyperglycemia, which is actually interesting. So you should go and watch it. I also talked about how normal glucose regulation occurs in the body. I also talked about what happens in type 1 and type 2 diabetes under simple flowchart patterns. And then I moved on to the clinical manifestations, like we have polyphagia, we have polydipsia, we have polyuria, we have impotence, we have blurred vision. So many things are there, along with the specific reasons behind it. So make sure that you watch that video so that when you come to this video, you get a continuity, and definitely if you make notes, it will be easy for you to comprehend what I am saying in this video as well. Also, since I am putting huge range of efforts in, because I make handwritten notes and then I convert them into slides that I'm going to present in front of you right now, and that is how I explain things to you. And this effort is literally painstaking and it takes a lot of time to make things easy for you. So please make sure that you subscribe to my YouTube channel and also follow my Instagram page under the same name, in which I share amazing reels on a daily basis, which will definitely catch your interest. So without wasting any time, let's go into insulin. So in this video, I'm going to talk to you about insulin, the smartest and the simplest way in which you can understand about insulin. So the headings that I will be covering under this topic will be a general introduction, just something for you to know in general, types of insulin, the different insulin combinations, what are the things that you should keep in mind when you think of insulin combinations, and what are the combinations that you should actually avoid. Adverse effects of insulin, and this is going to be very interesting because whenever we talk about adverse effects, we say hypoglycemia, weight gain, etc. But here I'm going to talk about some new terms that you might not have come to know or you might not be aware of. I'll be talking about Dawn phenomenon. I'll be talking about Somogyi effect. So I'll be explaining about that. Route of administration. Which are the different routes of administration of insulin? What are the different delivery devices? That different devices are available through which we can administer insulin in a patient. Just a small summary. Storage, injection sites, and administration. So obviously, insulin simply giving to the patient doesn't make any sense, especially if that insulin is expired. It can actually precipitate hyperglycemia, which is dangerous. And when you are administering, like which are the different body parts where you can administer insulin. Standard treatment versus intensive treatment. So this is like standard treatment means normally we are giving insulin to a patient, but intensive treatment means the patient is hospitalized with severe hyperglycemia, a severe hyperkalemia, all this condition. What is the difference between that? What is the advantage and what is the demerit? And definitely last is uses of insulin. And please remember that insulin is not just used in diabetes. There is another special indication for insulin. And that is why I mentioned this category. So without wasting any time, let's go into the details. So insulin is a polypeptide hormone. So it consists of two peptide chains which are connected by disulfide bonds. There is a lot of chemistry inside it. I purposely did not go into that because at the end of the day, I don't want to confuse you with oversaturation. So this is just a brief introduction. So basically, insulin, how it acts in our body is, there is a precursor. It's like a pro-drug kind of thing. So it is known as proinsulin. And this proinsulin undergoes proteolysis. And what do you mean by proteolysis? Proteolysis means breakdown of proteins. Proteo means proteins, lysis means breakdown. So insulin is actually a kind of protein. So this proinsulin, it undergoes breakdown and it gives rise to insulin and C-peptide. And both of these things are actually produced by the beta cells of islets of Langerhans of the pancreas. So basically, if you want to check insulin levels in a patient, C-peptide is actually a very good diagnostics test that you can go ahead with. So this is just a general introduction. Now let's talk about the types of insulin. So we have ultra short acting insulin, we have short acting insulin, we have intermediate acting insulin, and we have long acting insulin. I have also included a special category that is called inhaled insulin. Actually, inhaled comes also under ultra short, but I mentioned it separately. Actually, inhaled insulin is not that much clinically used now. So let's talk about ultra short acting insulin. So the examples are Lispro, Aspart, and Glulicin. Lispro, Aspart, and Glulicin. So basically, you can see a tabular column. So the onset of action is less than 15 minutes. That is why it is called ultra short acting. Always remember, short acting, anything that is short acting, the onset of action will be rapid, but the duration of action will be small. And if it is a long-acting medication, the onset of action will be slow, but the duration of action will be long. So ultra-short acting, you can see that it shows its action in 15 minutes. Peak action, what do you mean by peak action? Peak action means the action of insulin is what? Hypoglycemia. So the peak effect of insulin is seen within 1 to 2 hours. So after you get an injection of ultra-short acting insulin, you can experience hypoglycemia or the peak effect within 1 to 2 hours. Duration of action is 4 to 6 hours and it is clear in appearance. If you look at the vial or something, it is usually clear in appearance. This should be given 30 minutes before or after food or snacks to reduce the risk of hypoglycemia. So this is an important patient counseling that we should keep in mind. The onset of action, duration, and peak effects are independent of dose. That means even if you increase the dose of ultra-short acting insulin, it has actually nothing to do with the onset of action, duration, or peak effects. Mainly, ultra-short acting insulins are given subcutaneously. There is an exception, that is insulin aspart. Insulin aspart is actually given intravenous for DKA. DKA is diabetic ketoacidosis. But if you look at the guidelines or if you look into clinical practice, regular insulin is actually the drug of choice for diabetic ketoacidosis. Insulin aspart is only a second option. So we can actually use ultra-short acting insulin with long-acting insulin, and the examples are mentioned below: Lispro, Aspart, and Glulicin. Now we have short-acting insulin, for example, regular insulin. So regular insulin, please remember, it is the drug of choice for diabetic ketoacidosis, and it is given intravenous for the same condition. If you look at its onset of action, 30 minutes to 1 hour. Peak action is seen in 2 to 4 hours. Duration of action is 6 to 8 hours. And it is also clear in appearance. It should be taken at least 30 to 60 minutes before the meal. And if you increase the dose of regular insulin, the onset of action becomes faster. So here it is mentioned 30 minutes to 1 hour. You can see that onset of action may be in 15 to 30 minutes also. So if you increase the dose of regular insulin, the onset of action becomes faster. The time to attain peak action will be longer, Like for example, here the peak action is mentioned as 2 to 4 hours, but if you are increasing the dose, it can be 4 to 5 hours or 4 to 6 hours. And the duration of action also becomes longer. So please remember this. If you are increasing the dose of regular insulin, the onset of action becomes shorter, but the peak action and the duration of action becomes longer. It has a very high risk of hypoglycemia, because as you increase the dose, the longer time to peak action, and also the onset of action becomes rapid. So the risk of hypoglycemia is very high. This is used with long-acting insulin. It can be given subcutaneous, intramuscular, and intravenous. Intramuscular is not commonly used nowadays. We usually give it subcutaneous, and in very severe emergency conditions, we give it IV for diabetic ketoacidosis. Now let's talk about intermediate acting insulin. So basically, the insulin that comes in mind is NPH. NPH is neutral protamine hecdon. Neutral protamine hecdon. So basically, its onset of action is 1 to 2 hours. It shows its peak activity in 6 to 10 hours, and its duration of action is 12 to 16 hours. So it is usually cloudy or milky in appearance. Till now, the insulins that I talked about, they were clear in appearance, but NPH is the insulin that is actually cloudy or turbid kind of in appearance. It is also known as isophane insulin. So basically, NPH, how is actually NPH formed? So I have mentioned an equation here. NPH is equal to regular insulin plus zinc plus protamine. NPH is equal to regular insulin plus zinc plus protamine. Protamine is an amino acid. NPH is usually given subcutaneous. Never, ever give neutral protamine hecdon IV, and never even think about giving neutral protamine hecdon in emergency conditions. And whenever you give NPH, it has been seen that if you give it in the abdomen, if you are injecting it subcutaneously in the abdomen, the absorption has been observed to be more in comparison to the limbs. So it is always good to give NPH in the abdomen. It is used to control blood glucose level overnight. Why overnight? If you look at the duration of action and if you look at the peak action, so by the time you sleep, 6 to 10 hours is the peak action. That means it will continuously control your blood glucose level all throughout the night. So it is actually good for those patients who have hyperglycemic episodes after sleeping. And it is also good while fasting and also in between meals. This is actually combined with rapid or short-acting insulin, and it is given BD. BD means twice daily. Now we come to long-acting insulin. So we have three examples: Detemir, Glargon, and Degludec. These are the three examples of long-acting insulins. So they have certain differences. So Detemir is a bit different in comparison to Glargon and Degludec. So the onset of action of Detemir is 1 hour, but for Glargon and Degludec, it is 1 to 2 hours. For Detemir and this Glargon and Degludec, maximum effect is seen in 5 hours. For Detemir, the duration of action is 12 to 24 hours. That is why if you are using insulin Detemir, you should be taking it maybe twice a day. But for Glargon and Degludec, you can take it once a day. That is the biggest good news if you are taking insulin Glargon or Degludec, because they are literally long-acting insulin preparations. So you can take it once a day. And both Detemir and Glargon and Degludec are clear in appearance. So from this, you can understand that neutral protamine hecdon is the only insulin that appears milky, cloudy, or turbid in appearance. This is also used to control BGL. BGL means blood glucose level overnight while fasting and in between meals. This is given in combination with rapid and short-acting insulins. Now, there is a problem with insulin Glargon. Glargon actually has an acidic pH. So basically, you know that our body has a neutral pH, 7.35 to 7.45. So if you are injecting insulin Glargon, it actually precipitates in the neutral pH of our body, especially at the injection site, and it slowly releases the insulin. So since Glargon has an acidic pH, it should never ever be combined with other insulins, because most of the other insulins have neutral pH. So if you are combining acidic pH with neutral pH, there is a risk of forming white cloudy precipitate, which is not at all a good news. And that is why insulin Glargon should be given separately. It should never be combined with any other insulin. Insulin detamir is given OD or BD because its duration of action is 12 to 24 hours. So you can give it once daily or twice daily, depending on the diabetes. But degludec and Glargon can be given once daily. They are all given subcutaneous. And the biggest thing of long-acting insulin is that the risk of hypoglycemia is very, very low, because there is nothing exactly known as peak effect, because they slowly show their activity. The rate of absorption is very slow, and they slowly show their activity. And that is why the risk of hypoglycemia is very low. Now we'll talk about a type of insulin which is actually ultra short, but it's not that much used in clinical practice. It is called inhaled insulin. So I think it's a brand name known as Afrezza, which was approved maybe 1 or 2 years back. Inhaled version of insulin. So its onset of action is 1 minute. Imagine if you are taking that intranasally, the onset of action is just 1 minute. Peak action is seen in 12 to 15 minutes, and the duration of action is 1.5 to 4 hours. So it is actually available as oral inhaled powder, which is delivered via a cartridge. So this is mainly useful for those patients who are having diabetes in which postprandial blood glucose. That means if your blood glucose after meals increase, for those patients, inhaled insulin can be a good choice because the onset of action is 1 minute. So you should take this medication just before meals. This actually causes cough as an adverse effect, and the biggest bad news is that it can be bronchospastic. It can be bronchospastic. So this is totally contraindicated in patients with chronic obstructive pulmonary disease, asthma, and definitely smokers. Now let's talk about certain insulin combinations. What are the do's and don'ts? Neutral protamine hepdon can be combined with ultra and short-acting insulins in one series. That means first you draw short-acting insulin from the vial, and then you can draw neutral protamine hepdon in the same syringe, and you can give it to the patient. Long-acting insulin should never be mixed with short or ultra-short-acting insulin in the same syringe. They should be given separately. You should not mix in the same syringe. That's what I meant to say. Now let's talk about pre-mixed insulin in a single container. So these are 4 examples in which 2 different types of insulins are combined in a single container. So we have neutral protamine hepdon plus regular insulin in 70:30 ratio. We have neutral protamine lispro NPL plus lispro in a 70:30 ratio. We have insulin aspart protamine plus aspart in a 70:30 ratio, and we have degludec and aspart in a 70:30 ratio. Now let's talk about the adverse effects of insulin. Again, I have mentioned adverse effects. I'm not mentioning side effect here because the effect that you are seeing here is not something that is a good news. So it is known as Somogyi effect. SOMOGYI, Somogyi effect. So basically, if you are taking insulin before bedtime or at bedtime, sometimes these patients wake up in the morning with high blood glucose level. And the reason is explained here. Insulin usually causes hypoglycemia. So when it causes hypoglycemia, the body has a compensatory mechanism to counteract that hypoglycemia. So what it does is, it actually activates cortisol, which is a corticosteroid, and also adrenaline. And both of these agents are very notorious for increasing your blood glucose level. So that causes rebound hyperglycemia. Once again, insulin, when it is administered, it causes hypoglycemia. So this actually activates cortisol and adrenaline via a compensatory mechanism. They increase the blood glucose level. So the solution to this problem is you can reduce the dose of bedtime insulin and you can change the timing of insulin dosing. If you are using a high dose insulin at bedtime, then it will cause more hypoglycemia, then it will provoke more compensatory mechanism. So bedtime insulin dose you can reduce. Or maybe you can change the timing of insulin dosing. Don't directly give at bedtime, give a bit more earlier time. There is something called dawn phenomenon. So dawn, you know very well, in the literal meaning itself, it means early morning, early hours of the day. So it is a condition in which hyperglycemia occurs in the early hours of the morning due to insufficient insulin in the body. So the solution is that increase the bedtime dose of insulin. So you should actually be very, very careful in determining the dose that has to be given to the patient when insulin is given at bedtime, because it can lead to Somogyi effect also, and if the dose is very insufficient, then it can lead to dawn phenomenon also. So it's a challenge, but that is something that we need to think about. Lipodystrophy. Insulin actually has a tendency of redistributing fat from one area to another area. Okay, redistributing fat from one area to another area. Now, the problem with this is that if fat is redistributed from one area to another area, from where it is redistributed, there the fat content will be low. So there the fat content will be low, it is known as atrophy. And if it is redistributed to another area, there the fat content will be high. So that is called hypertrophy. So in such patients, you may see that on one part of the body, fat content is low. On the other part of the body, the fat content is high. This is called lipodystrophy. Dystrophy means abnormal shape or something. Trophy always refers to shape. So dystrophy means abnormal shape. This usually happens if you are injecting at the same part of the body multiple times. So that is why the solution is that you should always rotate the injection sites. This is a very important patient counseling tip also. You should not inject at the same site on a same day multiple times. Weight gain is also seen with insulin because it causes fluid retention, so that leads to edema, and that obviously indirectly can lead to weight gain as well. And this is also the reason why insulin is not the first choice for type 2 diabetes. If you look at the American Diabetic Association guidelines, if a patient is diagnosed with type 2 diabetes, usually we first prefer metformin with lifestyle modifications, because metformin has weight loss effect also. And also because in type 2 diabetes, obesity is also considered to be a risk factor. So directly we never go for insulin in type 2 diabetics. Unless and until your HbA1c level is above 10, that is glycosylated hemoglobin level is above 10, or if it is not getting controlled with oral hypoglycemic agents, only then you should think about insulin in type 2 diabetics, because insulin causes weight gain, and for a type 2 diabetic, weight gain is not a very good option, or I mean, weight gain is not actually a very good sign. Till now, you have seen that I said adverse effect, but here I mentioned side effect. This is why I say that you should actually see my, you should actually follow my Instagram page also. In my Instagram page, and in fact, in my YouTube channel also, I have explained the difference between adverse effect and side effect, which we actually get confused about. Adverse effect means the pharmacological action of a medicine is always going to be negative, but in a side effect, it can be both positive and negative. So here it is a side effect that is both positive and negative, and that is called hypokalemia. So how hypokalemia occurs? Insulin actually takes the potassium in the blood and transports it into the cell along with glucose. So obviously when potassium is going into the cell, the quantity of potassium in the blood reduces. So that leads to hypokalemia. And this is actually good for those patients who are suffering from CKD, that is chronic kidney disease, as well as diabetes associated chronic kidney disease. Because in diabetes, obviously, you need to reduce your blood glucose level. And at the same time, in CKD, hyperkalemia is seen. So in such patients, insulin is a very, very good option. Hypoglycemia is a very, very common adverse effect seen. And that is why it has been written in the first point. Insulin has a low therapeutic index. It is highly, highly dangerous. Low therapeutic index means what? If the dose increases a bit more, just a bit more, a fraction more also, the patient can go into hypoglycemia. And hypoglycemia means your blood glucose level will be less than 70 milligram per deciliter. Some people don't even realize that they are having hypoglycemia until the blood glucose level goes below 55 milligram, and that can be life threatening. Because if you are not rapidly treating those patients, they can go into coma and they can, die also. So if you are having severe hypoglycemia, IV dextrose is the treatment of choice. If the patient is conscious and they can take any oral glucose formulation, then you can give them fruit juice, you can give them glucose biscuits or candy. But if the patient is unable to take oral agents, then you can go for intramuscular or intranasal glucagon. And obviously, advising the patient is very, very important. Patient counseling. First, wherever you go, if you are taking insulin, you are going outside, you are sleeping at your room, or maybe you are in the bed, wherever, always keep sugar candy or biscuits in your bag, or even if you are at your room also, you can keep it on a study table or whatever. It should be nearby you, so that if you get the first symptoms of hypoglycemia, you can immediately consume it. And another patient education that we should give is, you should actually be able to identify the symptoms of hypoglycemia. There are many people who actually get admitted into the casualty and who actually pass away also because they actually never realized that they were having hypoglycemia. And by the time it was diagnosed, it was too late. So what are the symptoms of hypoglycemia? The pictures that you see on the left hand side are the symptoms of hypoglycemia, and this I have actually taken from Lipincot's pharmacology reviews. In fact, I'll come with a YouTube video on what are the best books that you can study for pharmacology. I always prefer Lipincot's pharmacology reviews because you just look at the adverse effects that has been shown here. It has been shown in pictures. Most of the textbooks, they write in simple sentences, and it becomes boring. You don't even remember. But when you are seeing in pictures, you tend to remember better. So the symptoms of hypoglycemia are mentioned here. You can have headache, you can have anxiety. Anxiety, why? Because when you are having hypoglycemia, cortisol gets increased. So cortisol can lead to anxiety, and your sympathetic nervous system also gets activated, which leads to anxiety. It can cause tachycardia thanks to the sympathetic nervous system. It can make you disoriented because if glucose level reduces in the brain, it will not function properly. It can make you disoriented. Obviously, hypoglycemia leads to vertigo because you will not be able to, glucose is less means you will feel dizzy. It can lead to diaphoresis. Diaphoresis means increased sweating. And this is also a symptom of, cholinergic nervous system getting activated. So you can have diaphoresis. Shakiness, it is also known as tremor. So that is also an effect of sympathetic nervous system. Increased appetite. Now, this is very interesting. If a patient is suffering from diabetes, especially type 2, they have polyphagia. But if you are giving insulin also, the patient will have increased appetite. What is the reason? Because hypoglycemia is seen. So when glucose level is low in the blood, it will trigger a compensatory mechanism in which the body will tell you that you have to eat something because glucose level is low in the blood. So that is why insulin can actually increase your appetite. And this is also another reason why insulin is not the treatment of choice in type 2 diabetes. Because in type 2 diabetes, we always focus on lifestyle modifications. weight loss. In that condition, if you are directly using insulin, it will increase your appetite, it will again increase your body weight. So how will the diabetes get managed? It can lead to blurred vision because it causes vertigo. It means it something related to that. So it can cause blurred vision, weakness and fatigue, obviously because of hypoglycemia. Lipodystrophy, as I said, it will transport fat from one area to another area. So one area fat content will be less and in another area fat content will be more. And hypersensitivity also, because it depends on from which animal or what, from where you are deriving this insulin. So if it is recombinant, the chance is very low. But if you are deriving it directly from an animal or something, your body will start sending antibodies or something. It can cause hypersensitivity reactions in certain populations. If you look at the route of administration, it is usually given subcutaneous. Intramuscular is not very common. Inhalation is also not very common. And intravenous is given, as I said, it can be given for severe conditions of diabetes, like diabetic ketoacidosis. There is another term mentioned here, HHS, hyperosmolar hyperglycemic syndrome. I'll talk about these terms in future videos, and severe hyperkalemia as well. Subcutaneous is actually easy and convenient. So that is why that is the most common route of administration. Now let's talk about insulin delivery devices. So it comes in 5 routes: syringes, pens, pumps, jet injectors, and inhalation. Please remember, jet injectors and inhalation is something that we don't commonly use nowadays. So let's talk about syringes. It is the most common form of delivery, which is given subcutaneous, and the syringes usually come in a variety of sizes. Pen is something that is very, very commonly used because it consists of disposable cartridges. So basically what it is like a pre-filled plastic disposable pens. So they have self-contained insulin cartridge. So this is actually patient friendly also, because usually when you are giving through a syringe, you require a trained healthcare professional to do it because patients may not use the syringe properly. But when it comes to a pen, you don't need a healthcare professional to stay with the patient to give it. The patient can be educated to do it by himself or herself. And nowadays we have durable pens also. Durable pens means it is like a, what do you say, a refillable pen. Like a lot of pens that we are using for writing, we have refills also, right? So durable pens means they have replaceable cartridges. So they are also usually used nowadays. If you talk about pump is actually an implantable device. So it is actually connected to subcutaneously placed cannula. So this helps in continuous delivery of insulin. So this is actually a programmed mechanism in which sustained release of insulin is seen. This is usually implanted, and the benefit is that there is no need for multiple injections because it is already implanted through a cannula. So it will do its work on its own. Jet injectors, it uses high pressure narrow jet of insulin. It usually penetrates the epidermis, but these things are not used nowadays. And inhalation also, I told you that it is not very commonly used nowadays. If you look at the storage and administration of insulin, if the vial is not opened, then you should refrigerate it at 2 to 8 degrees and in the middle shelf of the refrigerator. But if the vial is under use, then it can be stored out of the refrigerator. Only thing is that you should keep it away from source of heat and light because it's a protein can get denatured, and it can be stored in a patient's medication drawer or purse for up to 28 days. This is just a very small summary that I mentioned. A lot of details are available. You can refer it out. Abdominal wall is the most common injection site used. We can use other areas also, like the back of the arm, or maybe in the thigh and in the upper buttocks. Only thing is that to prevent the side effect, which is lipodystrophy, you should rotate the injection sites frequently, and the injection site should also be clean. Now let's talk about standard versus intensive treatment. So this is interesting. Standard treatment means normally a patient is diabetic, we are giving once or twice daily injection, normally. Intensive means the condition is serious. So there we go for 3 times or maybe 4 times daily regimen. So that is called intensive treatment. So the benefit of intensive treatment is it can control your HbA1c, because please remember, if your glycosylated hemoglobin is greater than 10%, it is called uncontrolled diabetes, and it can actually lead to different types of complications like diabetic retinopathy, diabetic neuropathy, etc., etc. And in intensive treatment, there is also another benefit. It helps in the control of diabetic complications like retinopathy, neuropathy, and nephropathy. The demerits of intensive treatment is that there is a high risk of hypoglycemia and subsequent seizures and coma. Why? Because there you are using multiple doses of insulin. So, if you are not correcting hypoglycemia accordingly, it can lead to coma and death as well. So if you look at the uses of insulin, so basically it is used in type 1 diabetes, type 2 diabetes only in uncontrolled. As I said, if you are having diabetic complications, or if you are having HbA1c very high, fasting blood glucose very high, then you can think about it. Diabetic ketoacidosis, we usually give regular insulin IV, hyperosmolar hyperglycemic syndrome, and hyperkalemia, because I already told you that insulin takes the potassium in the blood and puts it inside the cell along with glucose. So it is good for the treatment of hyperkalemia, especially in CKD patients. So these are the uses of insulin. So I hope that you have got an idea about insulin in the smartest way possible. I hope I have covered most of the important points in the simplest way possible. If you have any doubts, please make sure that you contact me at Instagram, because I have an Instagram page under the same name. So you can follow my page and you can contact me regarding your doubts. And in the next video, I'll be talking about metformin. So metformin is an oral hypoglycemic agent. So I'll be talking about metformin. What are the things that you need to keep in mind? What are the patient counseling tips, and what are its side effects or adverse effects along with its reason? So that is also going to be a very, very interesting video that is going to come soon. So to stay tuned, make sure that you subscribe to my YouTube channel, and definitely please share your feedbacks, because your feedbacks are gold. It's literally gold, because all the response that I have got till now has been the motivation for me to serve you better and better every coming day. So please make sure that you subscribe to my YouTube channel and also follow my Instagram page for more amazing updates. That's it for now. See you in the next video. Until then, it's bye.